Welcome to the Ethos podcast. I'm Ivan, the editor-in-chief of Ethos. I'm in New Haven, and with me here today is Professor Mark Mercurio. He is a professor of pediatrics at the Yale School of Medicine, and he did his undergrad at Princeton and his MD at Columbia. He is a chair, fellow, or member at many bioethics centers, including the Hastings centers. He is also the founding director of the program for Biomedical Ethics at the Yale School of Medicine, and also the founding director of the Yale Pediatric Ethics Program at Yale New Haven Children's Hospital. It is an incredible honor to have him here with us today. So how are you doing, Professor?
I'm doing very well. Thanks so much for the invitation, Ivan.
I wanted to first ask you about you as a founding member of the fellowships at the Auschwitz for Study of Professional Ethics. Could you tell us more about this program and what it does?
Sure. So the fellowships at Auschwitz for the Study of Professional Ethics, which we call FASPE because it's a mouthful. So FASPE is an organization that brings medical students, law students, journalism students, business students, tech students, and seminarians, various future professionals, and teaches them professional ethics, but in a very unique setting. The students travel to Germany and Poland and learn about the Nazi era and the involvement of professionals during the Nazi era. And in particular, after learning about that and learning that history and seeing the sites where many of these extraordinary events happened, then we discuss contemporary ethics issues. So at the group that I lead, the medical ethics, the medical students, we talk about contemporary issues in medical ethics. But in the context of or having learned about the role of physicians during the Nazi era and in the Holocaust and various atrocities that took place over that time. And so it's a unique opportunity for students, not just medical students, but other professional students as well.
So a question I've always wanted to ask is, given your experience in bioethics and teaching and interacting with medical students, do you think good doctors, like morally good doctors, are born or taught? Or do you think they're simply selected for in a medical school, like in the application system?
Oh, I think they're taught. But I don't think they're necessarily taught in medical school. I think they're taught at their mother's knee and at their grandfather's knee and so on and so forth. I think they're taught over the course of their lives. And certainly we hope that some of the selection process for medical school helps with that. But I don't think it's very easy in the selection process to really pick, to really take a good measure of that in an applicant. But I think it's what we're taught throughout our lives, including during medical school and the medical training afterwards. But so much of that I think is what we're taught coming up.
Would you make of the fact that Germany had bioethics programs in their medical school prior to their mass killing in T4?
Oh, I guess there's much we could make of it. One thing we can certainly make of it is that kind of teaching and the bioethics programs is no guarantee of what we would consider acceptable or ethical behavior by a physician or anybody else later in life. German medicine was rightly seen as a real bastion of scientific and medical progress. That was in German medicine was highly regarded, and rightly so in the early part of the 20th century. And yet they went so badly off the tracks, off the rails, I mean, and it's fascinating to study how that happened, because the point being that this wasn't just a few crazy guys. This was, many German physicians, the German medical profession largely, that participated in these atrocities during the Holocaust and during the whole Nazi era. And there's important lessons about how that might happen, and that things that you might consider a guarantee, such as bioethics training, is certainly no guarantee. And of course, the lesson for us, we teach all this to our students, and we continue to try and learn these lessons ourselves, not just because it's interesting historically, because the idea is going forward, we hope to reduce the likelihood that this sort of thing happens again. And of course, these sorts of problems are not unique to Germany either. Obviously, Germany is an extraordinary historical example, but certainly the medical profession has gone badly off track in the United States and many other countries as well. And there are examples that you're familiar with, like the Tuskegee study is the most famous in the United States, but there are others. And so being a very highly educated, both in medicine and in bioethics, is not a guarantee that things are going to go right.
Here's a hypothetical. If you were in charge of the bioethics program in Germany before World War II, what do you think you could do?
Wow, that's a really interesting question, Ivan. Let me think about this a minute. So what could we teach to try and prevent that from happening? Because, of course, that's directly relevant to what I teach now here. Because the idea being is one of the many missions that we have here is to make the future physicians in the United States more likely to choose the right path when they come to these difficult questions. So there's a lot of things we can teach that we do teach. Is what we're teaching now really going to make for better doctors going forward? I hope so. We're constantly working on it. But of course that, time will tell. Specifically, the things that we teach about these historical examples. I mean, I teach about the Holocaust here to our medical students. Here's an example of where our profession went badly off track. We teach them both philosophy as philosophy on a relatively simplistic level compared to philosophy grad school or something. We teach them a bit of that, but we also work through many difficult ethical problems with them over the course of their education to see if they can apply the principles that we teach and the virtues that we encourage to specific problems. And hopefully what we teach them is to value and respect everyone. I mean, the direct answer to your question, if I could go back and somehow teach these young physicians, to teach them to value and respect everyone. I think one of the lessons is that as soon as we can view people as something less than human, something less, some group has a lower moral status, suddenly what we do to them matters less. Suddenly we have more license to treat them as we like. And one of the things we teach here, and perhaps one of the things I would try and teach there, is to guard against viewing any group of individuals as something less, as having a lower moral status, if you will, among people.
How was biomedical ethics education now compared to your time when you were in Columbia many years ago?
Well, there's much more of it. I'm trying to think, the biomedical ethics education when I was at Columbia, we're talking about the late 70s and early 80s, there really wasn't much of it. There was, one or two classes, and I remember thinking these are not very good. And I remember thinking, unfortunately, we got to get back to memorizing 1 million facts so we can graduate medical school, But to pause and to take the time for that stuff, there really wasn't the devotion to that then that there is now. And now, thankfully, it's, throughout the 4 years, the medical students receive some formal didactic teaching and some informal teaching. What I do think we had then, and I have to acknowledge, is what I had then is many, many excellent role models, people who I sought to imitate, really good physicians. Physicians like Dr. Ken Ford, like Dr. Ed Bowe, like many others who I wanted to be like. And so you learn how to treat patients in large part from watching other physicians. Of course, the truth is you can learn bad habits as well as you can learn good habits by watching others. What we had then were some wonderful role models.
So moving on to neonatology, one of your most famous work is about the IPO framework in approaching neonatology and ethical considerations. Could you talk a bit more about what this framework is? Sure.
So this framework. It came about after I was a visiting professor someplace, and they asked me, and you give a formal lecture when you do this stuff. Then at some point you get to just kind of meet with the residents, and they ask you questions. And the residents asked me a question about a case, and it was a case of a possible or proposed intestinal transplant in a newborn, which is really, it's done, but it's pretty far out there in terms of things that are available. And what I thought they were going to ask me was, in this case, this was a newborn who had lost his intestines. I believe it was a volvulus, but I can't recall the details of that case. I thought they were going to ask me, would it be okay to offer them the possibility of intestinal transplant? Offer the parents this. Instead, what they asked me was, and it caught me by surprise, was, are the parents obligated to choose intestinal transplant? Now, no one that I'm aware of has ever suggested that parents of a newborn are obligated to choose something as dramatic as an intestinal transplant. And it's a long, hard road to get there and a road afterwards. So this is not something we've ever thought that parents were obligated to do. But the residents were asking me this based on some data that they saw. And I thought, well, this is a fascinating question. We talked about it for a bit. But when I came back, I actually sat down with my fellow then. Her name was Christy Cummings, and she's actually on faculty at Harvard now. And Christy and I said, Christy, we need to come up with a framework, a way to approach questions like this. It's really interesting. Rather than just dismiss them, let's think about why some things are things that we expect parents must do, some things that we say parents must not choose, and other things where parents get a lot of discretion. And so, we came up with this, basically defining 3 zones, right? Ethically impermissible. These are things that we don't offer and that we wouldn't do if we were asked as physicians. Ethically permissible. These are things that we think are allowed but not really obligatory, some treatments. For example, in neonatology, some kids at borderline viability, the very, very lowest gestational age, we consider resuscitation and critical care to be ethically permissible, which is to say we offer it if parents want it, but if they choose not to go that route with their child, we don't think they're obligated to choose it. Then the third category would be ethically obligatory. These are things that you have to choose. So if your child, if your otherwise healthy child has a life-threatening bacterial infection, we would say, well, antibiotics is something that is ethically obligatory. And parents, we would not say parents get to just say, no, never mind, don't treat him. So the interesting and hard work became, well, how do we figure out which zone to assign proposed treatments to? And that's something that that we talked about then, that I've written about, that I've continued to write about. And Christy and I actually just wrote something in, I think it was 2020, kind of updating the whole thing after a lot of experience in teaching it and thinking about it and writing about it. But defining the limits, and I think, put simply, I think proposed treatments go into one of those 3 categories based on the prognosis with and without the treatment, on the feasibility of doing the treatment, and on the relevant rights of everybody involved. And so, on one level, you can look at the framework very simply and say, well, just got these 3 categories, great. But of course, it's a much more nuanced conversation when we try and apply those criteria to various proposed treatments to figure out exactly where they fall in that framework.
Have you or any of your colleagues started applying this framework to other specialties?
So I have taught this in many places. I get invited here or there and talk about this, and other specialties have heard it. How much they've applied it, I can't say for sure. What I can say is that this is meant primarily for the pediatric world, and the pediatric world has certainly accepted it. So I've heard from folks say, what, I remember you gave that lecture. I've got a little picture of your framework tacked up over my desk, someone once told me, at a medical center a few states over. And so some people have heard it and have used it and found it helpful. We've applied it to various questions, particularly in neonatology. My clinical work is in neonatology, so I have certainly applied that to try to understand certain treatments. For example, the treatment of patients at extreme prematurity. And we've applied that and worked through it. The potential of treatment of kids with trisomy 13 or trisomy 18, and where, when, and how they should fall into those categories. And other issues, other proposed treatments for kids, I have applied on an individual basis. I've done a lot of ethics consults over the years. I chaired the ethics committee here at Yale for many years, and now Dave Hirsch chairs it. I'm still on that committee. And very often when we consider cases that are brought to us, we frame our discussion and our answer in terms of that IPO framework.
So what actually drew you first into bioethics or into ethics consultation?
Well, neonatology did. And so as a neonatology resident, as a pediatrics resident, doing neonatology and other things, it occurred to me that there were some really difficult ethical issues in neonatology. That always has been one of the real hotbeds, if you will, of bioethics within medicine. Of course, one of the most famous cases was the baby doe case of 1982. It was out in Indiana. This was a baby with trisomy 21 and a tracheoesophageal fistula. And the question was whether the tracheoesophageal, you have to, again, I'm not sure who all is listening to this, but this is a brand new baby, and a tracheoesophageal fistula is basically an obstruction of the tube and a connection between the trachea and the esophagus, an obstruction of the esophagus such that it's impossible to drink, it's impossible to take in nutrition orally unless this is surgically repaired. But it was reparable even in those days. It was reparable. This case was, I think, in 1982. But because the child had Down syndrome, trisomy 21, it was decided that would not fix it and just let the child die. And this became a very important case, kind of a landmark case in ethics. And of course, I was training around that time. And so I was learning these things in real time. And the conversations of which treatments we must do, for example, now we would consider the treatment, the surgical repair of a tracheoesophageal fistula in a child with trisomy 21, now we would consider that ethically obligatory. At that time, it was not felt that way in the world of pediatrics and in the world of surgery. Many cases like this at the time during my residency and fellowship made me very interested in this stuff. And then, frankly, the first job I took, they said, "Oh, you're a neonatologist. You'd be an interesting guy at this hospital to have on the ethics committee." So I said, "Sure." So that was the first time I was ever on an ethics committee. And most of the cases I heard, in fact, were adults on that committee, though there were some kids. This was a general community hospital. But I got more and more interested and eventually began teaching, began reading, went to grad school and so on. But the exposure to those early cases got me interested.
Wow. So speaking of neonatology, what advice would you give to someone who wants to go into that specialty, to medical students or even to young people who are interested?
Well, it's a very different field than it was when I started. And in some ways it's better and in some ways it's not. It's certainly much better for the patients, thankfully, than it was. Neonatology is a tremendous it's a tremendous way to work with all the organ systems, a variety of diseases and all the organ systems. It's a chance to work, very closely with parents. But one doesn't develop the relationship over the course of years that you might, for example, in primary care. On the other hand, compared to something like emergency medicine, where you develop sometimes an important relationship with people over the course of hours, we in neonatology, days, weeks, or months, we develop these close working relationships. And some neonatologists do long-term follow-up and have longer relationships. But for the most part, neonatology is over the time, it's a weeks and months sort of thing. It can be very exciting. That's one of the things that draw me to it. I mean, it can be life and death. It is sometimes life and death. A resuscitation in the delivery room, which is commonplace in neonatology, is a very exciting thing. And unlike a lot of other resuscitations in medicine, unfortunately, most resuscitations in neonatology end up with a good result. You can have a huge impact on people's lives. If you have a good day in neonatology, you might just have bought somebody 80 years. That's exciting. I mean, a win can be a huge win. Of course, the stakes are very high, and sometimes things are tragic. So the advice I would give, I guess, is to be aware of all that sometimes one has to think and move very quickly, and sometimes it's a life and death situation. One has to be able to work with families in a life and death situation. And sometimes it's many long hours doing things that are relatively tedious. It can be all of the above. I guess the best advice I would give a student who's interested in doing it is to spend some time in a newborn intensive care unit and see exactly what they do, and spend some time talking to neonatologists and see exactly what they do. Because there's now many different, if you went to a community hospital and followed a neonatologist for a day, that might be a very different experience than if you went to a very busy, large university NICU and followed the neonatologist for a day. So get exposed to some of these things if you're interested. It's a marvelous career, but it's not for everyone, so get exposed.
Just a slightly personal question, but how do you cope or stomach with the tragedies that can happen in neonatology department?
Yeah, I mean that's a hard question. I guess I imagine other people have thought of this before, though I don't know that I've specifically read it. For me personally, since you asked a personal question, I'll tell you. For me personally, there's two kinds of tragedies, and one is more difficult by far than the other. So if a child dies, despite our best efforts, there's nothing we can really do to save a child. That's tragic. And that can, it's just a horrible experience for, of course, for everyone involved. For the parents are suffering, and so much of our efforts have to be not about ourselves, but toward the parents. Even after we're done treating the child and we can do no more, we've got to help the parents through this. But we also have to recognize that the staff, that we sometimes suffer. And some of these are very hard for me. And it's sometimes hard to predict which ones are going to hit you the hardest. Sometimes it's just catching the look on a young mother's face or on a young father's face. And then that really hits you. Some of these tragedies can be very hard. The ones that are much harder and are the ones where you think, you know what, maybe if I had turned left instead of turned right over the course of a very long, difficult night, I might have been able to save that child. So the one where you think, if I had done a better job, I might have been able to save that child. Those are particularly difficult because you kind of add not just the tragedy and the empathy that we all hopefully feel for the kid and for the families, but then we add to that a sense of potentially culpability. Maybe I didn't do as well as I could have. Those are particularly hard. And one way that we handle those is we talk to each other. We help each other out. If someone wants to read something, there's like a one-page essay about this in the Hastings Center I wrote years ago called Rituals of Unburdening. So if someone just Googled Rituals of Unburdening, they'd probably find it, or Googled that plus my last name, Mercurio, they would find it. And then get a sense. I think that article gives you a sense of what it can be like. And sometimes we have to help each other through that. What did I miss? What can I have done differently? Now, of course, we could just comfort each other and always tell him, man, you didn't miss anything. You did the best anybody could do. And that's commonly the case. But then after things settle down a little bit, it's valuable for us to take a look and say, well, what could we have done better? Because it ultimately is not just about the patient we lost. It's about the next patient who comes in. And, so we have to look at those cases where it's tragic and not just say, that makes me very sad. I feel really bad for the family. Not just say, gee, are you sure I did okay to our colleagues? But it's to take a look at those. And this is the hard part. Take a look at these and say, hey, man, what could we have done better? So that if we counter this another time, what might we do differently to make it a good outcome more likely? That's hard to do, but that's necessary.
Wow. So another slightly personal question is, do you feel burnout often?
Well, you feel tired often. Now, to tell you where I am in my career, you could have talked to someone far more interesting because 2 years ago, I stopped doing clinical neonatology. I did it for decades. I was the chief of neonatology here at Yale. And when I stepped down as chief, I stopped doing clinical work also. And I focused my work just now, at this point in my career, on medical ethics. But, 4 decades of neonatology, of pediatrics and neonatology. So I've got an awful lot of experience with that. But so if I think, did I feel burnt out then versus now? Now I certainly don't. Then did I ever feel burnt out? Then sometimes I felt tired because it could be exhausting. It wasn't unusual. It isn't unusual to have to work a 30-hour shift. That's a long time to be responsible for a lot of critically ill patients. I mean, I've worked and others have worked to make that so that it isn't that way anymore. It's not that way anymore here. But tired, yes. Burnt out, I wouldn't say that I felt necessarily burnt out. There were times when I needed a break, no doubt. It can be really stressful, no question.
What do you see yourself doing in 5 years or continuing going down 10 years?
10 years, wow, that's pretty good, because I am relatively senior. What I see myself doing in 5 years, for the next 5 years, maybe even the next 10 years, is, as I say, I've stopped doing clinical work. So I don't work, frankly, as long and hard as I used to. But I still work a lot. I still come in on Sundays because there's no meetings and no one's around, and I got all day to write, either a talk or a paper. I see myself doing a lot of teaching and a lot of writing, and possibly some organizational work, helping create centers of pediatric ethics, helping create conversation in adult and pediatric ethics. As you know, I host a seminar series here at Yale, and I enjoy doing that a lot. I bring in some wonderful speakers, so I keep learning from them. So writing and teaching and organizing ethics work will be the 3 things that I'll likely be doing for the next several years.
So here's just some very short questions. What do you do for fun?
For fun? Well, I do a few things for fun. So I love the water, and I had boats over the course of my life off and on. I had boat the whole time my kids were growing up. They're all up and out now, but I had a boat from the time they were growing up, and we spent time on that and had great fun. And I sold that and bought another one recently, a bigger boat, and so I spend a lot of time on the water. And I put fun in quotes because, it's just always something. Just when you think, well, we're having a real good day and then something else goes wrong with the boat, So it's a fun frustration. But last winter I took a captain's course, and I had to learn a lot. But for me, that was fun. I like learning about the water. I like learning about boating and navigation and the water. That's fun for me. I got a dog. That's a lot of fun. I take him down to the beach many days. My wife and I like to go to the movies. We're trying to learn how to play tennis. She's not bad. I am bad, but we're learning, and that's something I spend some time with, and I've made some new friends with that, and I enjoy that a lot.
What was your childhood dream job?
My childhood dream job, wow. I have to say, fairly early in childhood, well, I think the last place it ended in childhood was to be a family doctor somewhere way out in the country, which, of course, family doctor way out in the country is kind of the opposite of being a critical care or a doc in a medical center, but there you have it. Family doctor out in the country. Before that, I think it was veterinarian.
Wow. So my final question is, well, I see you at talks and presentations, and you're always joking and you're so happy and you're always very witty and also so full of energy. So how do you keep that level of energy all the time with you?
Well, I'm glad you think I'm funny and witty. It's too bad I didn't say anything funny and witty during this podcast. I should have thought of something, but I appreciate the kind words and what how I keep the energy up. I mean, I get tired like anybody else. I love this aspect. I love being in front of a room full of students. I love leading a seminar. It's fun for me. I loved leading rounds. Sometimes they went on for such a very long time. But I enjoyed being with a group of residents and practitioners and students. I enjoyed being in a room full of people. I like talking about medical ethics. Part of where my energy comes from, and some of it's my nature, and I like people, so I like doing that stuff. But a lot of it is because this work, the medical ethics work, is fascinating. So people are charged up. It's easier to make medical ethics interesting to an audience than it is to make the details of blood gas management to make that interesting. Well, actually, I find that pretty interesting too, and if you get the right audience, they'll like it too. But some aspects of medicine are drier than others. Medical ethics is fun, and so the students, once you get them in there, it's something that everybody can get into, and it's enjoyable to talk about it, to work that part of our brain, which in medicine, frankly, gets a lot of rest, that part of the brain. That's a different analytic part of the brain, and it's fun to bring that out in students. So if I seem energetic, if I seem like I'm enjoying it, it's because the subject matter is really interesting to me, and I like, the people in the room.
Well, Professor, thank you for your work. You're a very inspiring teacher, and thank you for your time here with us today.
You're very kind. Thank you so much.